Text 1. Stroke. Introduction. Stroke causes sudden loss of neurological function by disrupting the blood supply to the brain. It is the biggest cause of physical disability in developed countries, and a leading cause of death. It is also common in many developing countries. The great majority of strokes come on without warning. This means that for most patients the aims of management are to limit the damage to the brain, optimize recovery and prevent recurrence. Strategies to prevent strokes are clearly important. They concentrate on treating the vascular risk factors that predispose to stroke, such as hypertension, hyperlipidemia, diabetes and smoking. The two principal pathological processes that give rise to stroke are occlusion of arteries, causing cerebral ischemia or infarction, and rupture of arteries, causing intracranial hemorrhage. Hemorrhage tends to be much more destructive and dangerous than ischemic stroke, with higher mortality rates and a higher incidence of severe neurological disability in survivors. Ischemic stroke is much more common, and has a much wider range of outcomes. Cerebral ischemia and infarction. Reduction in the flow of blood to any part of the brain first causes ischemia. A reversible loss of function, and then, if the reduction is severe or prolonged, infarction with irreversible cell death. The blood supply to the anterior parts of the brain, and to the eyes, comes from the two carotid arteries, which branch in the neck to give rise to the internal carotid arteries. These branch again in the head to give rise to the anterior and middle cerebral arteries. The posterior parts of the brain are supplied by the two vertebral arteries, which join within the head to form the basilar artery, which in turn gives rise to the posterior cerebral arteries. The internal carotid and basilar arteries connect at the base of the brain through the circle of Willis. This anastomosis allows some crossflow if one of the supply arteries is occluded. But the extent of this varies enormously from patient to patient. Beyond the circle of Willis, the cerebral arteries are best thought of as end arteries. Restoration of normal perfusion in tissue made ischemic by occlusion of one of these end arteries cannot rely on blood reaching the ischemic area through anastomotic channels. Recovery of function in the ischemic tissue depends much more upon lysis or fragmentation of the occluding thromboembolic material. The usual cause of occlusion of one of the cerebral arteries is acute thrombus formation at the site of an atheromatous plaque. The thrombus can occlude the vessel locally or throw off emboli which block more distal arteries. This process is particularly common at the origin of the internal carotid artery, but can occur anywhere from the aorta to the cerebral artery itself. A less common cause of occlusion is embolism from the heart. In younger patients, dissection of the carotid or vertebral artery, in which a split forms between the layers of the artery wall, often after minor neck trauma, can either occlude the vessel or allow a thrombus to form and embolize distally. Patients with hypertension or diabetes may occlude smaller arteries within the brain through a pathological process which may have more to do with degeneration in the artery wall than atheroma and thrombosis. This small vessel disease may cause infarcts a few millimeters in diameter, termed lacunar strokes, or a more insidious illness with dementia and gait disturbance. If complete recovery from an ischemic event takes place within minutes or hours, it is termed a transient ischemic attack, TIA. Where recovery takes longer than 24 hours, the diagnosis is stroke. The pathophysiology of the two conditions, and the implications for investigation and treatment, are the same. In both situations, the history and examination help to establish the cause, with a view to secondary prevention, and assess the extent of the damage, to plan rehabilitation. Symptoms and signs of the cause of cerebral ischemia and infarction. The common conditions which give rise to cerebral ischemia and infarction are listed below. 1. Atheroma in either the large neck arteries or the cerebral arteries close to the brain. There may be a history of other atheromatous disease, previous angina pectoris or heart attack. Intermittent claudication of the legs, previous TIA or stroke. There may be a history of vascular risk factors, hypertension, diabetes, hyperlipidemia, family history of atheromatous disease. Smoking. Examination may reveal evidence of these risk factors or evidence of atheroma, with bruits over the carotid, subclavian or femoral arteries, or absent leg pulses. 2. Cardiac disease associated with embolization, atrial fibrillation, mural thrombus after myocardial infarction, aortic or mitral valve disease, bacterial endocarditis. Neurological symptoms and signs of cerebral ischemia and infarction. The loss of function that the patient notices, and which may be apparent on examination, depends on the area of brain tissue involved in the ischemic process. The following suggest middle cerebral artery ischemia. Loss of use of the contralateral face and arm. Loss of feeling in the contralateral face and arm. Dysphasia, dyslexia, dysgraphia, dyscalculia. The following suggests anterior cerebral artery ischemia. Loss of use and/or feeling in the contralateral leg. The following suggests posterior cerebral artery ischemia. Contralateral homonymous hemanopia. Involvement of face, arm and leg with or without a homonymous hemanopia suggests internal carotid artery occlusion. The ophthalmic artery arises from the internal carotid artery just below the circle of Willis. The following suggests ophthalmic artery ischemia. Monocular loss of vision. Combinations of the following suggest vertebrobasilar artery ischemia. Double vision, cranial nerves 3, 4 and 6 and connections, facial numbness, cranial nerve 5, facial weakness, cranial nerve 7, vertigo, cranial nerve 8, dysphagia, cranial nerves 9 and 10, dysarthria, ataxia. Loss of use or feeling in both arms or legs. The following suggest a small but crucially located lacunar stroke due to small vessel ischemia. Pure loss of use in contralateral arm and leg. Pure loss of feeling in contralateral arm and leg. Ian Wilkinson, Graham Lennox. Essential Neurology. 4th edition, pages 25 to 29.